it's very hard when planning courses to know, you know, I hope so this first half of the course has been really dedicated to relatively simple things that you can do at home with or without sophisticated technology. You can do trans-epithelial PTKs. You can use your Wavefront-guided or topography-guided systems to make repairs. But hopefully you understand the basis of how to use these tools, and particularly you become a little bit more aware of the centration differences between Wavefront-guided and topography-guided. Angle kappa is the #1 element that you have to know a patient has before you decide on a repair profile. Alex Stojanovic, I don't know if he's here, he was here a little bit earlier, he uses the SIPTA system, and he uses a very clever way of centering everything that's nothing to do with the vertex of the cornea, which of course might be artificially changed because of the irregular zirconia surface. They use a generalized surface extrapolated from the peripheral cornea and to reconstruct what the cornea was like before surgery in the first place. So it's another clever way of thinking about the geometry of the cornea. But what I'm going to do now is move into shift gears into a deeper level of complication repair, and so I hope you'll stay with me. Feel free to interrupt me. Put your hand up if there's something that's not clear. I would much prefer to be interrupted than to be speaking and not really being able to help you understand what I'm trying to say. Again, the modalities available to us are Wavefront-guided, topography-guided, but also, of course, Trans-epithelial PTK. Those are the modalities, and so I'm going to talk about the use of these. Now, diagnosis is everything. This patient normally, if I just showed the map, people would say decentration, obviously, right? But the fact is that this was a short nasal flap, right, with a pneumonia LSK1, but the ablation for -8 was still done. And so there was no tissue removed from the area where the flap was too short, right? And so there was an only ablation on one side of the cornea. And so this is a very severe problem. Now, these scans were, is that Gerhard? No, it's not. Okay. I thought it was Gerhard Yousefi because he was involved with me. He's the the Bausch & Lomb scientist. We sent him these ultrasound scans when we were in Vancouver 12, 13 years ago, and showed him anatomically that the short hinge was accompanied by a massive thickening of epithelium over the bump, which is the area where no tissue was ablated, where it should have been ablated. And we provided him with an epithelial thickness map because epithelium always compensates for stromal surface irregularities, always. Epithelium masks the true topographic and or wavefront error that must be corrected. Because remember, the topography is the surface of the epithelium, and remember, the wavefront is biased 80% to the front surface of the cornea because that's the big refractive surface. So your wavefront measurements in this case are wrong, and your topography measurements are wrong. By how much? By this much, by the thickness of the epithelium. And what we're doing surgery on the stroma, and then the epithelium has to re-even itself out. So we sent him the epithelial map with the idea of him subtracting the epithelium from the orb scan front surface to derive the stromal surface by that amount, which he did. And we devised a different profile. This was the original TopoLink, which was still in clinical trials, of course, as you know, wasn't released, but the TopoLink was then modified with a different surface, the stromal surface. And this is the ablation profile that was created. Now remember, if you look back here, if you just look at a best fit sphere here, you would have required removal of tissue from the temporal cornea. Right? That's the part sticking out of the best fit sphere. But once we calculated using the epithelial profile, we're now taking tissue where we logically would expect to take tissue from, which was the nasal cornea, because of the short flap where the tissue wasn't removed in the first place. Amazing how you can get it wrong by 180 degrees because the epithelium has changed the view to the world of the topographer. Okay? So we did this treatment, and I created a second flap underneath. It's very easy to make a thick flap in those days. You just use your moria, and then you get a big thick flap. I don't know how smart that was of me, but I did it. I got away with it. The residual stromal thickness was okay. This is the before total optical power map through the cornea, and this is afterwards. And you can see this is in 2000. This is 13 years ago. Like the first stromal-guided, topography-guided treatment, stromal surface-guided treatment, very effective. Let's go to some theoretical considerations, okay? And something which we call the law of epithelial compensation, meaning that you can have the same surface in yellow, but a totally different stromal surface underneath it, depending on the rate of curvature and where the location is on that cornea. Alfred Vogt, I have this book which was published in 1921 in my collection. In this, where he describes what to do with a slit lamp, he says, corneal stromal defects are filled in with surface epithelial defects. In German. My wife is German. She translated that for us. The way that I would like you to remember this is irregular astigmatism means irregular epithelium. By definition. If an eye presents with irregular astigmatism, by definition, the epithelium has reached its maximum compensatory function. Because if it could do more and completely regularize the cornea, then it wouldn't be irregular astigmatism. So the fact that there is irregular astigmatism means that the epithelium hasn't managed to fully compensate for the irregularity of the stromal surface. So, irregular astigmatism by definition means that there's irregular epithelium, but remember that it is only a partial compensation of the actual problem. Okay? And you also know, therefore, that the epithelium can do no more. So our aim with surgery, of course, is to bring the irregularity of the stromal surface to within the range where the epithelium can fully compensate for the irregularity of the stroma, which, by the way, is what saved refractive surgery of the cornea, because from the earliest days of PRK to 4.5 millimeter zone with the summit, we have been creating irregular surfaces, but the epithelium has very kindly gone and low-pass filtered this for us and created an optical surface that people can see through. So the epithelium is our friend, but we have to help it a little bit. And so the corollary to all of this is that, therefore, topography and wavefront-guided measurements are inaccurate means of describing the irregularity on the stromal surface. Fact. Now, I showed you earlier that the epithelium changes in all these situations: ectasia, keratoconus, myopic, hyperopic, radial keratotomy, orthokeratology. But of course, now if we go to the level 2, we're talking about how. And the answer is, it's all to do with the rate of change of curvature of the stromal surface. For example, a very limited, small, punched-out hole with a very high rate of change of curvature will get 90 to 100% compensation. And in fact, you may not even see it, as you know from a deep corneal ulcer, which eventually heals. Here's a deep corneal ulcer, 209 microns, totally filled in by epithelium, no surface defect on the topography. Completely, the evolutionary ability of the cornea to restore its shape is provided to us by the epithelium, but only because of the very high rate of change of curvature. This has happened here in the periphery, where there's a flap irregularity, and the epithelium is completely smoothed over. There's no dimple in the periphery of the flap. Now, going down to the same depth, if you reach that depth slower, in other words, if the rate of change of curvature is less, then the epithelium will be able to compensate less. And that's what we were seeing in the early days when we were doing 5 millimeters on treatments in the mid-90s, where the epithelium was causing regression, but not total reversal of the treatment. And we see that in small optical zone myopic treatments, but we also see it, of course, particularly in hyperopic ablations, because there's a very high rate of change of curvature, twice, one on each side of the center of the cornea. So we do see a lot of compensation. That's why you know if a +4 is -1 on day 1, you're happy and the patient's unhappy. But if the +4 is plano on day 1, the patient is happy and you're unhappy because you know you're going to have to go back in and do an enhancement, right? This is regression that takes place over time. And of course, as David O'Brart proved scientifically in the 90s, if you take an optical zone of 4.5, 5, 5.5, and 6 millimeter and compare the regression rates as you increase the optical zone, so you get less regression. And that was published in the mid-90s. Very elegantly, this was done. So as you know, when we use larger optical zones, there's less regression. Now, therefore, if we have highly irregular stromal surfaces, like for example, here's a case with an incomplete nasal flap and lots of microfolds in the cornea, so there's a lot of irregularities on the epithelium, on the stromal surface. The epithelium is very irregular all over the central area. Here's RK, where the incisions are sticking up, little plugs, and they're causing the epithelium is thin over the plugs and thick between the plugs, right? But the topography looks completely smooth. But this is actually what's going on, if you like, a mirror image of the stromal surface. Here's a patient who had multiple procedures, ALK, PRK, LASIK, flap, and each procedure created a circular section of thickening and thickening and thinning of the epithelium concentrically. Here's an example of a patient who was treated on a laser where the tracker unfortunately tracked in the wrong place. The tracker was set inferiorly, and so the hyperopic ablation took place across the visual axis. And so he had a totally decentered hyperopic ablation and obviously created a pretty interesting case, which I'm going to show you how we repaired later. So, first things first, easiest thing anybody can do, even with a 20/20 Vizix B or a Summit Apex Plus, and that is PTK. And I'm going to show you the power of trans-epithelial PTK. But I'm also going to show you what the limitations are if you don't have a knowledge of the epithelium. So here's a case where a patient had primary LASIK for low hyperopia with the Technoless 130 disposable nasal hinge, Postop 2080, corrected to 20/20 with some myopic cylinder. The decentration was diagnosed. Then the surgeon appropriately did a topography-guided treatment because he knew that it's better than a Wavefront-guided treatment. The diagnosis was decentration, but I showed you the short flap earlier, right, where there was I showed you that, and it was diagnosed as a decentration. So the topography-guided treatment was to treat the decentration, but actually it made the patient worse. It increased the double vision and ghosting, and the patient complained of headaches, starburst halos, and night vision. The surgeon then thought, well, if the topography-guided treatment didn't work, I'll do a Wavefront-guided treatment. Of course, that's now centered on the pupil, and coma is now relative to it, and it made it even worse. So at that point, we received the patient for an evaluation, and the refraction was very reasonable, and the best corrected vision was very reasonable. But the patient had severe complaints. And if you look at the topography, you can still see the ridge produced by this short flap. And you can see how there's truncation here. It's a very straight line here on this ablation profile. And you can see that the elevation map is sort of pushed temporarily. And you can see that there is coma, lots of it. Now the patient doesn't have a big angle kappa, so the wavefront measurement of coma is similar to the topography measurement of coma because they're centered in the same place. But we diagnosed what was the problem. It was a short flap. And here it is. Short flap with, so there's the flap interface, with a kink in the stromal surface near the hinge. How did this, and the epithelial surface, how did this occur? Well, we postulated, because we'd seen these before, that the flap was created, lifted, the ablation was performed, the hyperopic ablation was performed, but there was ablation on the underside of the flap. So tissue was removed from both those places, and when everything went back, there was double ablation, if you like, in that zone, causing this drop in stromal surface here. But this is, of course, not visible on topography, this dimple. It's filled in by epithelium. And there it is. There's the epithelial thickening coinciding exactly with that area. And, of course, the bump, which is outside of that area. Now, you can see it on fluorescein staining. I mean, that's, diagnostically kindergarten stuff, but there it is. So we knew, or at least the patient knew and the surgeon knew, that Topography-guided and Wavefront-guided didn't work, and now you know why it didn't work. Now you know why it didn't work, right? And so what we did was we said, well, the only way of guaranteeing where we're placing this ablation is by doing a trans-epithelial PTK. Because this is a diagrammatic example of this particular case. We flipped it around. But that bump in the stroma will come off first if you go trans-epithelially, because you're ablating epithelium on either side of that, which grows back. And here's how it works. If we simulate what would have happened in that case, we would have broken through in the middle and over the bump at 47 microns. By 59, we've pretty much cleared the cornea, and by 65, we're down to just that little hole, and we've removed this amount of stroma from this cornea. And this is the simulation of what the stromal ablation will be if we do 65 microns of trans-epithelial PTK. So before doing it, we check and see what it is that we're going to do. Eye tracking is irrelevant here because you're removing lamella of epithelium, and the epithelium is stuck to the stroma, so it's going to block beam just where you want it to block all the time, no matter where the eye is pointing, just as in case you're using a Physics 2020B. So the treatment was this, and we did the treatment, but let me show you what the topography-guided treatment would have done. So right where the epithelium was thickest, right where the stromal ablation would have been highest, down to here, you can see that does not coincide with where the topography-guided treatment would have removed the tissue. And inside here, in other words, the height and the width of this little slither of stroma that needs removing is completely different anatomically to what the topography-guided treatment was going to do. Why? Well, because the epithelium was filling this whole area, causing it to look flat, and causing the topography-guided system to decide not to take tissue from there because it's already flat. So to show you how this worked, we'll just rotate the scan, and this is now upside down, yeah? And we're going to look at that area diagrammatically like I showed you a minute ago. And here's a video of the actual process. So we start off. Can you switch the sound off, please? Thank you. We're just going to dry the surface and set the tracker somewhere in the middle and go through our trans-epithelial PTK down to 49 microns. And we chose 49 microns because that was a location where we could stop and compare what we achieved to what we simulated what we were going to achieve. And the reason for doing that is to see whether in this patient the epithelial abrasion rate is predictable. Because what we found is that although it's 1.3, this is for the expert, for the MEL 80, it'll be different from other lasers, depends on fluence. But for our laser, the ablation rate is 1.3 times, you have to multiply the ablation by 1.3 to get the same number of epithelial cells to be removed than stromal cells. So the epithelium ablates slower. Once we got to this point and found that we had the gap right there, and we had this area of exposure right there, everything exactly as predicted, we went on to the second part. Okay, and now here we are going further down into the stroma. and finally ending up with what we predicted was going to be a little bit of epithelium right there, and that's exactly what we ended up with, a little bit of epithelium there. And then we stop, because we know that if we try to get to the bottom of this, we're going to be taking away a huge amount of stromal tissue, not necessary, producing a hyperopic shift, and all of this other stuff that we don't want to do. But we did see lots of microfolds. I hope you sort of, sorry, I clicked too quickly. Lots of microfolds on the surface. And so that we then just went to our standard, what we call wet PTK technique, where, oh, I'm sorry, I missed a step. Sorry, I'm ahead of myself here. Because of the amount of stromal ablation that we had seen in our predicted, we knew that there was going to be a 1 diopter shift in hyperopia, right? PTK causes hyperopic shift. So at the end of this, we stopped at that point and then did a hyperopic ablation, which simultaneously removes the last bit of epithelium, smoothing it out. But now we're doing a curved correction to compensate for the hyperopic shift, which we predicted from our trans-epithelial ablation digital surgery that we had done before surgery. At that point, we then go and clean up these folds that are still remaining on the surface by what we call a wet PTK polishing. In this case, nothing fancy, you just put any fluid on the cornea. While the surface tension is holding the fluid, you do a PTK through that. You have to stop as soon as gaps start appearing. But basically, you can see how just in one go, those little peaks are sticking out of the water, or at least they get slammed by the shock wave of the X-ray laser and exposed. And so you can produce tremendous smoothing just by flooding the cornea and shooting into the water. Yeah? Anyway, the result of this case was the following. Here's that dimple that we had before. The dimple is now gone. Here's the epithelial map and the topography before, and here it is afterwards. Now, just with the PTK, remember, PTK, no topography-guided, we've now completely regularized the ring of the epithelial thickness. We've expanded, if you like, the optical zone. We've recentered the optical zone. The fluorescein staining map looks absolutely perfect. The patient is symptom-free, and we've effectuated a change in the topography, the axial curvature difference in the topography, but we've done it through a trans-epithelial PTK using the masking properties of the epithelium as our device, if you like. Now, here's another case, just to show you, another case of short flap where the epithelium is thicker in the trough and thin over where because it's a bump, where no tissue was removed. But just to show you some of the limitations of only being able to go out to 6 millimeters with OCT currently. I mean, on this eye, we did get an area where the epithelium was measured thicker, but it was only measuring it at about 70 microns, but it was actually 104. So we need these maps to go further out if the pathology is outside of the 6 millimeter zone. And remember, 6 millimeters is 3 millimeters from the vertex. That's really not very far. So 10 millimeters is really what we want. So you go and hammer OptoView to believe me that they need to go out to 10 millimeters, because I've already told them 50 times. But if you all tell them, then they'll think there's a product opportunity. If I tell them, they go, he's that crazy guy measuring epithelium for the last 20 years and no one listens to him. So here we go. So this brings us to the next level again, which is to think about the refractive impact of the epithelium when it's doing this compensation. And to illustrate that is a case that we had repaired and published because it's so cute the way everything worked out. This patient had RK in 1982, and then he'd had some extra incisions for presbyopic, trapezoid cylinder, one of these sort of Zorro treatments on the cornea. And 20 years later, he's plus 650 minus 8 at 110, best corrected 2050. His epithelium was highly irregular, but regularly irregular. In other words, it had like a sort of zone of thickening and 2 points of serious thinning, the epithelium, but relatively regular in that sense. The topography looked great. I mean, I'd be pleased with that topography. I just put some glasses on that, no problem, right? I mean, it's regular cylinder. But under there is a problem with the surface, and this guy's best corrected, nowhere near reflected by that topographic appearance. You would expect the best corrected vision to be way better than that. So there's a subsurface scattering or refracting of light because of the difference in refractive index between the epithelium and stroma, which is 1.401 versus 1.376. And that little difference makes a difference. So let's look at this theoretically. The epithelium in green, the stroma in blue, the epithelial surface is a topography, but it's misrepresenting the stromal surface by the epithelial thickness difference. So the front surface topography is different from the stromal surface topography, which Marine very cleverly did for us in Volpro CT by Ed Sarver and Associates. So we can see here, for example, on the the difference in keratometry from top to bottom was 5.8 diopters from the front surface, but it was 9 diopters on the stromal surface. So the epithelium had done a 3 and a bit micron compensation, diopter difference compensation for us. The topography does not represent the actual stromal irregularity. And so a topography-guided treatment is therefore trying to straighten out based on the surface of the cornea, which is removing that tissue. So if you remove that from the stroma, you're going to get remaining irregularity, which may or may not be compensated for by the epithelium, and therefore you can remain with irregularity. In order to have effective customized ablation, you need to have the information of the epithelial thickness profile, or measure it directly on the stromal surface with OCT. Okay? But you need that information. That's the repair tool that each and every single one of yours mission, at the end of this case, is to march directly to your company's laser booth and to say, we need stromal surface guided topography treatments, please. Even though it's going to cost you millions, because it's going to make you billions, because we can blow the confidence in LASIK wide open if patients felt that there was a safety net. Because this patient, slight digression, the epithelial refractive effect is different for myopic than hyperopic cases. And just think about how this works in cataract, post-cataract corneal power measurements. You've got your, Snell refraction through the cornea, ray tracing, whatever you want to call it. But the power shift produced by the myopic ablation is a minus shift, whereas in hyperopia, it's a plus shift. So in hyperopia, you have a hyperopic contact lens on the stroma, and in myopia, you have a myopic contact lens on the stroma. And yet, the K reading on the surface doesn't know which one of these two it is. And that's why the Haggis formula has a different formula for post-hyperopics, because they're different. Okay? And the thing is, rather than doing multivariate regression analysis, ray tracing, and all this schmancy stuff, why don't you just measure the epithelium and measure the power through the epithelium and then measure the power through the stroma, and then you know what the corneal power is. So again, you need to go to your companies and tell them that epithelial thickness measurements in 3D are critical to cataract calculations for us. Thank you. Back to the programming, the regular programming, after that little advertisement there for epithelial thickness mapping. If we were to simulate this case, we would break through at 40 microns. That's what, at 45 microns we start taking stroma, 50, 55. So the actual stromal ablation would have been 24 microns from that point and that point, and 0 microns in the middle because we haven't gone through the epithelium. Wow, that looks awfully like a hyperopic astigmatic treatment, doesn't it? And if we model it, we find that two peaks 4 millimeters apart at 24 microns equals a 3.5 diopter cylinder treatment. Oh, all right, well, let's try it. So we did this, and we treated this patient, and we stopped at 45 microns, again, like I said, to check that the ablation rate was what we expected it to be, which it was, and we continued treating to the end. What was the result? 9 months post-op, just a trans-epithelial PTK, nothing else, no topography, no nothing. So we're trying to correct any refraction here. We're trying to pare down those bumps that were sticking up into the epithelium so that our topography map looks more like what we need to do with a topography-guided treatment. And look what happened to the cylinder. The cylinder went down by 3.9 diopters, exactly as we predicted from our pre-op simulations. And this is the epithelial thickness profile before, and here it is beautifully afterwards. Highly symmetrical, nothing irregular about it. Which means, because the epithelium is regular, we can use a topography-guided treatment now, because now the topography does closely resemble the stromal surface. And so it should work, right? So the next thing you need to do after the course is to go to your companies. Okay, so corneal topography minus epithelium equals stromal topography. Okay, that's first grade corneal complication repair arithmetic. And this is what happened when we did that topography-guided treatment. Not much. Actually, we didn't do that well. We got, oh, I didn't mention that we got the best corrected back to 2020 just from the trans-epithelial PTK. So that subsurface irregularity, which was not showing on the topography, was all we had to do to get the patient back to 2020, best corrected. We took that 2020i, did a topography-guided treatment. Remember, this is the original topography, and now it looks like that. So it's a lot better, but we're still refractively quite far away from the planet. And you're right, sometimes you have to do 2 stages because the epithelium has power. And as you saw, the epithelial thickness profile had cylinder in it here. So this was not compensated for by the topography-guided. There's a cylindrical epithelium. So we went and did a second topography-guided treatment, and now the post-op surface looked phenomenal. I think you'll agree, almost like a pre-op. So this is the original topography, and here's the post-op difference map, and the patient ended up literally plano 2020. If Alex was in the room, he would have said, but Dan, you could have done that all in one treatment by just using the remaining irregularity, which is what the epithelium couldn't do, as the epithelial mask and the topography at the same time. So if you do a trans-epithelial PTK, you basically translate the epithelial surface down to the stromal surface, right? You translate that surface down to the stromal surface, and then the topography-guided treatment takes care of the rest of the irregularity, and now you've got your perfect surface. This is the Alex concept, and it's good. And in fact, he's published his results. This was last year, last year, and the results are great. I mean, he has good refractive accuracy and good outcomes. However, it wouldn't have worked in this case. It wouldn't have worked in this case because this patient had 3 diopters of cylinder that was hidden, and as you did the trans-epithelial PTK, you would have changed the cylinder of the refraction. So it's not about the irregularities in isolation to produce a smooth surface. It's about what the refraction is going to be after you're finished with all of this. And in cases where you have limited amounts of tissue to play with because the patient has probably already had a couple of repair attempts by the time the patient's got to you, now tissue is a premium. You don't want to be wasting any tissue, and you certainly have plenty of time because time is your friend. You want to go in steps. So conservation of tissue is the issue, and so a stepwise approach, in my philosophical opinion, is always the best way to go because topography-guided treatments are sometimes not required. as you saw with the short flap case that we did there, where the guy was repaired without any further tissue removal with one treatment, which was a trans-epithelial PTK, with a clever calculation as to how much hyperopic, shift there's going to be, and we adjusted that, and that's fine. An epithelium can compensate for the final part of the thing. So you can do a combined topography-guided treatment, as Alex is suggesting, of course, if you've got plenty of stroma and you don't mind doing an enhancement for the refraction. If the epithelial profile looks reasonably good and doesn't seem to have a particular refractive shape to it, or if the local irregularities are causing all this epithelial change and they're really not going to have a global effect on the refraction. And that was the case with this patient, who was 58-year-old NASA engineer from Florida who had big problems with his left eye, having had ALK, then AK, then LASIK, then a second flap LASIK, then an enhancement, I don't know which flap was lifted, and he had a low refraction but awful vision, according to himself. And when we scanned him, even though his topography looked quite regular, we found that the stromal surface was very irregular, even though his front surface was regular. And his epithelial profile looked like concentric rings representing each of the optical zones of treatments he had in the past. So a trans-epithelial PTK completely removed all of those ridges. A wavefront-guided profile on top of that was placed because he had no angle kappa, and we knew that the epithelial irregularity was not going to produce a refractive change because it was just rings. And so he ended up with a phenomenal one-time slam dunk contrast in the toilet, contrast high normal outcome by looking at by separating the very, very high irregularities, which are like 64th order aberrations, if you like, which is kind of scatter, really, as opposed to the wavefront, which is up to the 6th order, where the human being detects things. And this is an example of how you can combine these techniques. I've eaten up your time.
No, we've got ages.
Okay.
We've got half an hour.
Go ahead. Yes.
What are our options right now for the time being, as we do not have Artemis-guided at Cornell University? We have to take into consideration the epithelium.
Correct.
As you clearly explained to us.
Okay. So one option is to go to the RTView booth and buy one of those, and it's only in 6 millimeters, so it'll help sometimes.
That's the next half an hour.
Exactly. The other, I'm just going to tell him what he can physically do, but the other option is to listen to what Tim is about to say. Because what Tim's going to do now is, Tim is very kindly, for you, not for me, because he works for me, I have an Artemis, but for you, because you don't have an Artemis, and you don't have access to an Artemis. And by the way, if you send me an email saying, I wish I had an Artemis, that's it. My email's, just send me an email that says that, and I can use that as ammunition whenever I'm talking to anybody and say, we need 10 millimeters. I would be very grateful. You would be grateful, because eventually you'll have an Artemis. I had a very well-known colleague who derailed the commercialization of the Artemis last year by saying that OCT is going to be able to do all of that, which is a shame, because I like having both machines. But the answer to your question is, you can either measure it in 6 millimeters, or what you can do is do what Tim is about to show you, which is, if you don't have any of this information, what can you do blindly, no pun intended, to still be able to help a patient in your clinic? And that's the last part of the talk. So this is what you can take home, and you can do at home, something that you can try at home. Okay, Tim.